Welcome to Behind the Numbers, making sense of trends in the drug supply and overdose rates. My name is Merlene Tucker, and I'll be running today's web forum along with my colleague Jeff Bornstein. Today's web forum is sponsored by the National Overdose Prevention Network, a program of PHI Center for Health, Leadership, and Impact, and produced by Dialogue for Health. Let's meet the moderator of today's event, Dr. Mary Maddox Gonzalez. Dr. Gonzalez is a coach and preparedness consultant for the California Overdose Prevention Network, a program of PHI Center for Health, Leadership, and Impact. She served as the Sonoma County Public Health Officer and Division Director and the Chief Medical Officer of the Redwood Community Health Coalition for Sonoma, Napa, Yolo, and Marin counties. She has been a board member and chair of the Latino Coalition for a Healthy California. Welcome, Mary.
Thank you so much, Verlene, and welcome to all of you today's conference, our webinar. Just the number, we had over 1,000 people sign up for today's webinar. It is an indicator of the degree of interest in this topic. So we welcome you all. Can I have the next slide, please? So the National Overdose Prevention Network is funded by the California Department of Healthcare Services under the State Opioid Response 4 grant. And we are just so glad to be in our partnership with all of you in this important work. Next slide. Today, we're going to have, as I mentioned, very interesting topic of Behind the Number, making sense of drug trends in our country and locally. We're going to have a Q&A sessions. The Q&A, any questions you do have, please put those in the Q&A. We will get to as many as possible. And then I'll have the next slide, please. Today, you're going to learn about recent changes in the drug supply, also look at some of the contributing factors to the recent decline in our national overdose death rate, and then also understand why overdose rates are still increasing in certain communities. Well, now it is my pleasure and honor to introduce our speaker today. Dr. Nabarun Dasgupta refers to himself as a street drug scientist. He is a senior scientist at the University of North Carolina's Gilling School of Global Public Health. He has over 2 decades of experience in overdose measurement and prevention, and his passion is telling stories about health with numbers. He works at the UNC Opioid Data Lab with a team of scientists who explore difficult questions in overdose prevention. He also leads the UNC Street Drug Analysis Lab, and this lab analyzes over 12,000 street drug samples, identifying patterns in local and national drug supply. He is an advisor to the U.S. Food and Drug Administration, the Centers for Disease Control and Prevention, and the World Health Organization. In addition to all of this, he's the co-founder of 2 pioneering nonprofit organizations, Project Lazarus in Wilkes County, North Carolina, and Remedy Alliance for the People. Remedy Alliance for the People just did an amazing job in supplying over 1.6 million doses of naloxone across the country during a period of life-threatening shortages of the drug. For this and his many accomplishments, in 2023, he was named to the Time magazine list of 100 emerging global leaders. In granting Dr. Dasgupta this distinction, Time mentioned that few Americans have done more to prevent drug overdose deaths than Nabarun Dasgupta. We are so fortunate to have you, Dr. Dasgupta. Welcome. Dr. Nab, as you were referred to. Thank you.
Thank you so much, Dr. Maddox Gonzalez. All right, so these slides, we will go quickly. So these slides are posted publicly at this QR code, and I'll show you the QR code at the end again. Thank you for having me. Those poll questions are really illuminating. What is in the local drug supply? And I have to admit, I have trouble figuring out what's going on with the national drug trends. So the 50% of y'all who know what's going on, please let me know too. But I'll tell you what I think. So okay, so just up front, my funding and disclosures. Our funding here at UNC is through federal government, through state government, and foundations and nonprofits. And we do all our drug checking free and at cost, and our naloxone distribution, as you heard, through Remedy Alliance for the People is also free or at cost. So I don't take any money from industry. and don't have any specific conflicts to disclose. So I work at the Opioid Data Lab, which is a collaboration between the University of North Carolina, University of Kentucky, and the University of Florida. At the Opioid Data Lab, we have three groups of studies: theory, practice, and lived experience. These different projects. We start with foundational studies, with the theory ones, which are biostatistics, methods, psychology, and pharmacology. So really lab-based experimental things. Practice, the practice projects are applied research. So looking at pharmacy, the practice of medicine, the way we count overdose deaths. And then lived experience are community questions that we answer from community. And you'll see some more about that in just a moment. Our approach is different. We don't just do research. We'd like to think of it as science and service. Our goal here is to answer questions that are relevant to you and your communities. We are not solely driven by trying to make generalizable knowledge, but rather our goal is to find ways to bring knowledge, to bring information to you so that you can make knowledge out of it in your local context. So we know that the drug supply changes constantly, but we don't know what's in street drugs until it's too late, when people are either dead or they're arrested. There's no opportunity for prevention and there's no opportunity for recovery. In order to change this paradigm, at UNC, at our lab on campus, we monitor the street drug supply as a public service. Using this innovative kit that we developed based on COVID test kits, harm reduction programs, health departments, clinics, hospitals, drug user unions, EMS teams from around the country send us drug samples in a way that is where the drug sample gets inactivated and is allowed to be mailed across the country. We just need a tiny, tiny bit of the substance. And so powder, these tiny little scoops, less than a grain of rice, the swab of an empty bag, a piece of a pill, or a used cotton, which is used for filtering drugs before injection. So this is kind of what I'm showing you now is how I know what I know and sharing how we collect this information and get it back to community. This is Ainsley Bryce out in Appalachian, North Carolina at Holler Harm Reduction. Really important, the samples are given to us voluntarily and the test results are anonymous. So we don't know and we can't trace back to the individual that the samples come from. But we also post the results publicly, as you'll see. We collect a little bit of information because molecules by themselves don't tell the full story of what's going on with overdose or drug-related harms. We need to know a little bit more of the context. So this is a very simple card that we have in our kit that collects just enough additional information to give us context to the molecules. Molecules don't tell stories, humans do. And we really need these stories to understand what is going on in the drug supply. Our packages arrive on campus by FedEx, and yes, we are in compliance with all laws. We have a lot of people looking over our shoulders, so trust me, we are good to go. This is the laboratory building. We process the samples in. When they come into the lab, we process these and get the data all ready for analysis. We prep the samples, and we use a machine called GCMS. And so this machine is able to identify every single thing that's in a particular drug sample. And so what's really different from what you would do, like say in a hospital where you have a panel where there's a pre-specified list of drugs that you're being tested for, we can actually, because we're getting the solid drug samples, identify every single thing that's in that drug sample. And we are able to report that back. And so that's called untargeted search. So there we go. We've analyzed about 12,500 samples as of last week, and they have come from 43 states and 252 counties from around the country. We've detected 418 unique substances in the drug supply. I think most of us can name like a dozen or a couple of dozen: coke, heroin, meth, like what you're used to thinking about. But what we see on a regular basis is a lot more variation in the drug supply. This is not intended for something to like look at and understand, but this gives you a sense of the range of chemicals that we see in the street drug supply. We see about 120 substances per month on average, and about 418 total since we started, and about 10 to 15-ish substances new that we detect every single month. So when we get the results done, we post them on our website. There's a QR code in the kit. And most importantly, this QR code allows the sample donor to get the results back that they donated to us. Our real goal here is to help people make better decisions about what they put in their bodies. And this is really important because we want to prevent future harms, not just figure out what happened. What's been fascinating is the way that people have used this technology. And this is the same technology that's been used in forensics for decades, just to put it into a new paradigm. And what's been really fascinating is the way that people have used these kits to answer questions that are relevant to their communities. These are just some examples from clinics, from harm reduction groups, trying to figure out how accurate test strips are. We can provide a gold standard measure for that. And even things like samples coming from widows who have whose husband may have been smoking just meth, but they're being told that their husband had died of an overdose, and they wanted to get closure because the process um, for the autopsy takes 8 months or so, and so they wanted to know sooner what was it that killed my husband. So this work is really hard for us some days, and but it's really not just about the molecule. It's really understanding what is happening in communities with people who use drugs and respecting what they have to say back to us. We use statistics. I'm a statistician by training, and I love my numbers. And we make our data public daily, and you're welcome to use the QR code to look at our results every single day. The other cool thing we can do at UNC is when we detect new substances, some of them have never been ever tested in human beings before. We may have some molecular structure for it, but we may have no idea what it does in the human body. Our colleagues at UNC are able to do some predictive modeling and say, whoa, this one looks really potent. This is very similar to something we're concerned about. And we can provide that information back to the individual and the programs that sent us the samples. This is what a lot of people who use drugs are kind of say about the drug supply, that it is very variable, that it's very hard to understand, and the unregulated drug supply is not something that most people are satisfied with, especially the synthetic opioids. So now that you know how I know what I know, let me show you kind of 5 ways that I use to figure out kind of how make sense of the US drug supply. And here's the key insight. Trends in consumer goods show up concurrently in street drugs. So if you're not someone who deals with street drugs on a daily basis, but you are someone who eats food and lives in this world, you will find these examples will help pin these 5 concepts for you. So the first is polysubstance. So all illicit opioid exposure is polysubstance. It's never just fentanyl. It's never just heroin. So here's an example. Okay, so energy drinks, I don't know if y'all have noticed, but they have gone crazy with the number of adulterants and other additives that are in it, right? So this is just something you can buy at Walmart. Sorry, I don't get paid by Walmart, but some say you can buy this somewhere, right? But it has all these substances in it. And some of these, like even though I'm a chemist, like a street drug chemist, I don't really know what some of these things are. So it's very hard, even if it's labeled, to know. So we see a similar trend in the street drug supply. Here's a sample that was sold as fentanyl in February in Durham, North Carolina. And it has all these things in it. It has 2 over-the-counter medications, Tylenol and Benadryl. It has a weak unregulated opioid called tianeptine, which doesn't have an overdose risk, but has a bad withdrawal risk. That's really kind of like pretty specific to North Carolina. And then there's 3 medications for schizophrenia, nausea, and a paralytic medication. And then you have anesthetics in here. You have synthetic opioids like fentanyl, but you also have plant-based substance stimulants like cocaine, and you have some additional cuts and plastics and kind of other nasty adulterants. So when people say that they're taking fentanyl and you're helping them kind of with prevent withdrawal or treat their symptoms from their drug use, the really important thing to remember is that it is never just fentanyl and it is never just opioids. In contrast, crack and methamphetamine are usually very pure and are very rarely are adulterated much, much less frequently than the synthetic opioids. Okay, so that was one. Number 2 is counterfeits. So There was this really fascinating study that was done where a nonprofit went and sampled fish from grocery stores and supermarkets, and they did genetic testing and chemical testing to figure out what those fish actually were. I guess it shouldn't be much of a surprise that 50% of things that are like a white flaky fish, like sea bass or snapper, are mislabeled. They're not actually sea bass or snapper. And that's like not that surprising, right? But down here, lobster also gets mislabeled sometimes. How do you mislabel a lobster? Something that distinctive, right? Something so distinctive we think of as like fentanyl as this like really distinctive kind of potent molecule, right? How do you mislabel something like that? Well, it turns out that that was lobster ravioli. It was something that had a very distinctive form, but was repackaged and put into a form that was unexpected and unrecognizable. The same thing happens in the street drug supply. And we see this specifically with fake pills. And you'll see like this pill is supposed to be alprazolam, which is a benzodiazepine or Xanax. And this one has no alprazolam or Xanax. Instead, the only active ingredient is fentanyl, and it looks very much like a fake. The fake looks very much like the pharmaceutical version. So this is also happening. So number three are adulterants. These are unexpected additions, and I hate to do this to y'all, but chocolate contains some pretty nasty adulterants, specifically lead and cadmium, which in small amounts for adults is, fine. Maybe this explains my brain fog. I don't know. But for children's brains, these are things that you really shouldn't be putting, you shouldn't really be serving to your kids. And these are large amounts of cadmium, of these heavy metals. And ironically, the ones that are like that are called organic and fair trade tend to have higher levels of cadmium and lead. So when we think about kind of what we see in the street drug supply and compare it to what we see in the regulated food supply, we should be 0% surprised that there are adulterants in both of these things, right? If the regulated supply of caffeine and alcohol and nicotine has these adulterants and problems, it's obviously going to show up in the street drug supply as well. Sorry to ruin chocolate, but the good news is milk chocolate usually has a lot less. So I've actually switched mostly to milk chocolate. Sorry. Um, Let me give you an example of how this shows up in the street drug supply. So B-Temps is this it's a long, long name, but it's something that's used in plastics and pharmaceutical plastics as as a way to prevent UV rays from degrading chemicals or medicines. And this suddenly showed up in the drug supply last summer and kind of spread from West Coast to East Coast. But it was mostly found 88% of the time in our samples with fentanyl. And we've tested 1,250 or so samples with BTAMs from 16 states. What you see is initially there was a lot of it was like the blue line there is the primary active ingredient was this BTAMs, and then it now has become more commonly found, or just about it's found less as by itself and more kind of mixed in with other things. So these things happen in the drug supply, and they're a part of having an unregulated supply that we are living with. This one is seeming like it's maybe dipping out of the supply a little bit, but to give you a sense of one example. On the other hand, we also see things that are adulterants in the drug supply that also disappear from the drug supply. So acetamiprid is a insecticide. It's a kind of more commercial insecticide. And usually, we think of insecticides and dope as kind of a trope. It's something we expect to happen. But what's important for those of us who are trying to prevent harms is that each class of insecticides has different properties and different health harms. So it's not enough to just say, oh, it's bug spray. We're not surprised to see it in the drug supply. It's important to understand what class of molecule that is and what we can do to prevent those specific harms or treat them when they come into the hospital. And you can see with this one, we saw 6 samples in New Mexico and Washington State, and then it kind of just disappeared. And they were all clustered in like a 1 to 2 month period last summer, and then it disappeared. So this is something that's not on our watch list anymore. So just an example of things actually disappearing. The fourth way we make sense of the drug supply is variants. So these are small molecular changes that have big differences. So let me give you an example. This is another over-the-counter powder that you can buy that will help you sleep. And well, supposedly it says it will help you sleep. So one of the main active ingredients in here is called GABA, and this is what the molecule looks like. Don't worry, I'm not going to show you too many molecules, but this one will be obvious. There is just one molecule difference that just on the end here between GABA and GHB, which is a scheduled um, substance that is also known as roofies and is known for its very incapacitating effects. And so even like this one atom difference can have a huge consequence. And that's why it's important for us to actually monitor the drug supply with precision in a way that we can understand what's happening molecule to molecule, atom to atom. So here's an example of so here's an example of how this molecular nuance plays out. So xylazine is a veterinary sedative that also causes really bad skin wounds and withdrawal. You probably have heard of it by now. But since last June, we've seen a replacement of xylazine with a sister molecule called dexmedetomidine. And this one is just one or two atoms different, but has a really different profile. It's way more sedating, and we're not sure if it causes skin wounds yet. So we see this as something that is definitely coming. We've seen the drug supply, xylazine, kind of being replaced with this dexmedetomidine, which is again like a very much a consequence of regulated drug supply. As we clamp down on xylazine, this is the next thing that we are pretty certain is going to replace it. Fentanyl-related substances are called fentanyl analogs. There's a lot of attention to these. These are, again, small molecular differences between the parent, like the original fentanyl molecule, maybe like a hydrogen is different here, nitrogen is different here. And there's a lot of effort to like figure out what all these little ones are and kind of chase down all these potential variants. But in practice, 85% of fentanyl and fentanyl analogs are just two molecules, fentanyl and p-fluorofentanyl, which is just a little bit less potent than regular fentanyl, but similar. So even though there is a lot of consternation about kind of all these molecular variants, it's important to keep our eyes on the prize, like the ones that actually show up in the drug supply, the ones that are actually causing harms, and the ones we should be paying attention to the most. Finally, the last thing is potency. So this is the amount per unit. So I don't know where y'all live, but here in North Carolina, these are two types of liquor that you can buy. One you can buy at a gas station and one you can buy at a liquor store. And the amount of alcohol difference in these is almost double. And they look nearly identical. One is malt liquor and one is whiskey. And so when you see like this kind of potency fluctuation in the regulated market, you're expecting to see that in the street drug supply. That's exactly what we see. These are data from Vancouver, British Columbia, and where they were monitoring fentanyl concentrations in street drug samples, and their range was about the same, about about a double back and forth of the concentrations of fentanyl. What's really interesting is that this isn't like a line that just goes straight up. It's a line that goes up and down over time. And why that's important is that these dips in when the amount of fentanyl when fentanyl goes down, people tend to use more to compensate because their withdrawal gets worse, and that puts them at risk for an overdose. When the concentration goes up, it's kind of obvious, right? More amount per bag, people are not used to it. Then there's also overdoses. So when there's fluctuations up or down, those are the real risk periods for the increase in overdoses. Another example is carfentanil, and this is another synthetic opioid that is many times more potent than fentanyl. And we saw like a lot of overdose deaths with carfentanil back in 2020, and there's been some concern that this is spreading around the country again. But what we find in our analysis we've analyzed 81 of these samples from 10 states that contain carfentanil. But what we see is that the carfentanil is showing up in trace amounts, so tiny amounts. And it's really different from what we saw in a few years ago when the spike in overdoses was happening because carfentanil was in primary abundance and not just tiny little trace amounts. So it's not just about the molecular potency. You have to kind of understand it in context. It's really fascinating to me that something like carfentanil is emerging at a time when overdose deaths are declining. right? So it's not just a one-to-one correlation with potent molecule, more overdose deaths. There's a lot more that actually happens to increase people's risk of overdoses. So the other class of synthetic opioids that we're particularly worried about or keeping an eye on is called the nitazines. And these are another class of synthetic opioids that are incredibly hard to detect in autopsies. My colleagues in Ireland tell me that half of all overdose deaths in Ireland don't have an identifiable substance associated with them because they are these nitazines. And nitazines are something that have become kind of emerged in Europe and where they kind of skipped over the fentanyl problems. And so as fentanyl is something that gets cracked down on at a national level, we fully expect nitazines to be the next thing. So this gives you a sense of which ones we're seeing. So these are the 5 ways that we can use to make sense of the unregulated drug supply. We have polysubstance, counterfeits, adulterants, variants, and potency. So this will be kind of your shorthand for when you hear about a new drug trend, try to put it into one of these 5 categories. But in doing this work, there are a few paradoxes that we have to grapple with. The most interesting one, I think, is called the drug bust paradox. And this was a landmark study that was done in Indianapolis that showed that within a 6-minute walk of each drug arrest, opioid overdose deaths doubled for about a period of 3 weeks. So the Indianapolis Police Department, seeing this study, said, well, we're not going to stop taking drugs off the street, which is something that I think we can understand why our law enforcement colleagues are doing that. But the challenge for us in public health is how can we be ready when these drug busts occur to jump in with services? Do we know where people can get treatment right now? Do we need to surge naloxone to these areas? What else can we do knowing that this surge of overdoses is going to happen? And so this isn't just a one-off study. We've seen it in Indianapolis, and just last month, we saw a very similar result out of San Francisco. So pick your political leaning there, but the results were very similar: 74% increase in fatal opioid overdoses for about a week after each single drug bust. So this is something we have to contend with. We often think about overdose, kind of prescription opioids in the longer arc of how we got here. But prescription opioids, the 1-year mortality rate is only less than 1%. It's 0.02%. And what's really interesting about this to me is that if you look at the number of days between the last opioid prescription finishing and an overdose death, it's about 3 years, 2.5, 3 years. So you have 1,400 days in which you can intervene, when you can do something to help that pain patient kind of not be in pain, or help them kind of prevent going back to the street to get supplement what was cut off. So I think as a lot of folks who are involved in opioid settlement work, it's important to remember where the money comes from for that work, but also that things have changed substantially and that there is time to intervene. There is hope, and there is a way for us to help people. So thinking about kind of putting that number a little bit more in context, out of 1,000 people, how many people each year will die of an overdose? Well, if you continue to use fentanyl and other street opioids, your risk is about 10 out of 1,000, so about 1%. How do you cut that rate down? The easiest way to do it, the most effective way to do it, is methadone. And if you're on methadone maintenance therapy, your risk of dying drops about half to 6 out of 1,000. Now, this is the other paradox to think about. If you go into abstinence only treatment, your risk of dying of an overdose actually almost doubles to 17 out of 1,000. So the amazing conclusion here is that it is less risky to continue drug use than to go into certain types of treatment. Now, this is studies, this is a very important study, and you should definitely take a look at it. Don't take my word for it. But I think it's time we have these hard conversations about what actually works, what is proven to work. And if we want overdoses to keep going in the correct direction, we need to keep numbers like this in mind. So now we can get to the overdose trends in the US that we've been seeing over the last few years. We put out this blog post last September, and a lot of the information that I'll cover here, we go into a lot more detail in the blog post. We'll give you a QR code at the end to look at. But this is kind of the national snapshot, the most recently available data from about a month ago. But actually, the data go through, I think, November of 2024, and we're down 26% overall from peak. Sorry, not from peak, from November 2023 versus November 2024. This is something that has not happened in the 20 years that I've been doing this work. We've never seen a reduction in drug overdoses of this magnitude. And so, well, the first question is it real, right? I mean, you have every reason to be skeptical because these numbers are atypical from what has come for the last 30 years. So the way that we figured out, well, the way we convinced ourselves, or the way we evaluated this, was we looked at fatal overdose rates. We looked at hospital emergency department visits for overdose and 911 calls. If all three of those are showing similar declines, then that gives us a lot more confidence because these are three windows, three independent data systems that are getting three perspectives on the same phenomenon. And what we saw, and you can see that in the blog post, is exactly that all three are down similar levels of magnitude. Here's the takeaway that I really want you to remember. The US experienced a gradual decline in overdose deaths over 3 years when you look at this state by state. It wasn't just this abrupt thing that shows up on the national figure. When you look at this state by state, it's actually a very different story. And this is important because this suggests to me that the work y'all are doing on the ground, caring for our neighbors and our family members, that is the work that is making a difference. It is not just a sudden thing like a change in the drug supply or some kind of border action. That alone cannot possibly explain this phenomenon that has happened gradually over this entire time period. Let me show you some data on that. So this is from NPR, and these are data or CDC data that we processed for them for this. And what you can see is that overdose deaths started peaked, like the highest level of overdose deaths on record, and everything after that has been decline. And that peaks in different places in different years over from 2021 to 2024. By the end of 2024, every single state was declining in overdose rates, which is amazing. But here's the truth. Drugs don't sweep across the continent like a weather front. Instead, it's more like skipping stones across the surface of a pond. And so when we look at these maps, when we look at these numbers on a national level, it's really important to dig into the state level. So now I'm going to use this type of graph that we created to give you a sense of kind of some of the state level nuance that I think is really important to understand what's happening in your local area. So this is the black lines that you'll see are the CDC overdose mortality data. If it's red, then it's higher than average. If it's blue, it's lower than average. And we're looking at a period from 2020 to the end of last summer. Okay. So first, let's stay with this point on geography. So can the drug supply really explain the geography of decline of overdose rates? So here's three cities, Wilmington, Delaware, Baltimore, Maryland, and Washington, D.C. It's about 100 miles between those three cities, and it takes, anywhere from 2 hours to like infinity hours to actually drive that area. But what we can see from the actual overdose data is that even these three places that are separated and so closely together had really distinctive patterns in what's happening with their overdose deaths. In Maryland, the overdose deaths peaked in 2021, whereas in Delaware, the peak was more like 2023, and DC was more like 2024. And you can see that Maryland and Delaware, the rates have come down a lot from their peak, whereas DC is lagging behind a bit in their recovery from the peak of overdose deaths. So the takeaway here is that local information matters a lot to explain what is happening with drug trends. And even in places that look close-ish on a map, there might be completely different systems that are happening in those areas. state by state, we have this graphic that you can see. You can use that QR code to download it and take some time to look through it. But this gives you kind of a feeling of what we see for overdose trends nationwide. But let me go into a little bit more detail and not kind of obsess over these tiny little graphs that are hard to see. The first takeaway is that 19 states have returned to pre-COVID levels of overdose mortality. This is a huge accomplishment. This is actual results from the actual work that y'all have been doing on the ground for so many years. This is something to be proud of. But it's also important to remember that way too many people we love are still dying. Our jobs are not over. But we are making progress and there is hope. And this is not something that is so far out of our reach that we can't actually address it. We can do this. What's kind of putting my nerd hat back on, what's interesting about the shapes of these curves is that they kind of fall into two categories. One are A-shaped curves, and these are like one big peak of overdose and then kind of coming down. And we see this kind of all over the country. There isn't like a distinct geographic pattern. Indiana looks very A-shaped to me, and so does Maine, but so does Washington and Alaska. So these are like single peak kind of overdose problems. We also see M-shaped curves, which means up and down over this like 5-year period that we are coming out of. And I think these are also interesting because this is where you need your local data. So this could be different like major cities in your, if you have like two different big population centers, maybe these are two different population centers. Sometimes we see differences by race, and sometimes the overdoses happen in one race first and another race after that. So it's really important to then have your local data to make interpretations of what is actually happening. One way we look at this, so this is the California numbers, is to kind of go into a little bit more detail, where we take the CDC monthly data, compare it to the predicted data, which is kind of that national graph that you saw earlier. And the orange lines are the actual overdose deaths. And then you can just pay attention to the blue for now. Then that's kind of the CDC predicted numbers. And the reason why we're seeing a decline kind of happening on a national number in 2024 is because California started declining in overdose rates in actually mid 2023. And the way the statistics are done at CDC, it takes about 6 to 8 to up to 12 months for those declines to register in the national picture. But there's a lot more detail here, and I'll give you one example with Arizona. So Arizona, this is like from the CDC website, and it looks like, well, overdoses went up, and they've had a long plateau, and maybe they're trending down a little bit. But if we make our inferences based just on that, we're going to get this wrong. If you look at the monthly data in Arizona, it tells you a very different story. What do we see here? We see 4 spikes. We see like these big spikes that happened, and they happen consistently in July of each year. So the overdose problem in Arizona gets exacerbated in July. And what do we do? Like, how do we think about that, right? It's like, it's the nexus of of people who are unhoused, heat, age, all sorts of other things, right? But it's really this nexus that happens in July of every year. So while the national data are helpful, looking at the state data, I think, are more important because you can see these patterns that allow you to more efficiently target your resources and your spend to help people in need at the right time. So in closing, let's look at what's working and what's left behind. I'm going to skip this because we've talked about it. So here's an example from Lake Charles in Louisiana. So they started seeing a increase in emergency department admissions for overdose, and they rolled out this amazing low threshold buprenorphine program, and they've been able to drop the overdose rates in the ED significantly. What's really important, these numbers are interesting, but what's really important is I want you to look at these faces. These are the people who are doing the work. This is often the invisible work that doesn't get talked about. And there are often gender differences that we don't talk about in terms of who is doing the actual caregiving that is saving lives. I think this is something we should be explicit about and provide support to the people who are actually doing the work. Similarly, what we see in Missouri and St. Louis is a decline in overdose deaths across Missouri, 23%, and largely due to naloxone distribution. Once again, let's look at these faces and see who is doing the work. What's fascinating here is because of the way that St. Louis worked with their Black communities, Black residents in the St. Louis metro area, the overdose death rates declined by 46% during this naloxone distribution because they got it into the hands of people who had traditionally been left out of the process. So once again, the people who are doing the work on the ground, which is you all, really need to step up and tell your stories about how to do this right and give us all some hope of what we can do when we work together. Speaking of who's left behind, I recommend this report on Native Americans and our Native Alaskan communities that the Brookings Institute put out last year. The podcast is really good with Philomena Quebec, who's from the Bad River Tribe in Wisconsin, but this is the rest of the story that really needs to be heard. In closing, public health is working. Y'all keep going with what you're doing. Keep going. So these are the 6 things I would say as the takeaways. Use your settlement funds wisely. This money is there to support your mission, and go ask for it. Do not be shy, and bring your receipts, show that you're doing the work. And you can often, we often look at the statistics and numbers to drive the story. But oftentimes what I find is in rural areas and local communities is people know their interventions are working because they know the people who are still alive. These are people we went to high school with. These are people who are our friends in our churches and our community, and they're still alive because of these interventions. And sometimes it's those stories that matter a lot more than having some academic tell you what the numbers are. I think it's also important, though, speaking of those numbers, where science is important, which is that not all interventions are created equal, and they're not all equally distributed. So I think it's really important to keep that in mind. We've talked about who's being left behind and how we bring them to the table. Sorry, these are out of order for some reason. As I've made clear, local information is really important. And it's also time to think about other drug-related harms, skin wounds, hepatitis, endocarditis. And finally, I'm going to put in a plug for our under-resourced medical examiners, who are the ones who provide us with, who do this invisible work of assessing what happened when someone died. And I think we should do more to resource them more fully. Our mail-in drug checking service is available nationwide. And I will thank our awesome team who keeps everything going. And I'm happy to look at the Q&A. And please sign up for our newsletter.
Thank you so much for that excellent presentation. I can see by the number of reactions, the surprise at some of the data. Look at the applause right now, and the appreciation for these very important observations that you've made. We have so many questions to get through. I'm going to jump right to these. Some of the questions that were asked have actually been answered by your comments. So I'm going to go to some. One individual asked that mentioned their leading cause of death from overdose is related to meth. Comments that you might have, perspectives you might have on how to prevention of those overdose deaths.
Mm-hmm. Yeah, meth is a really interesting thing. So some states, you'll see data that says meth was involved in the overdose. Philip Coffin at UCSF actually has a really good paradigm for this, which is to think of meth more like alcohol than opioids. So with alcohol, we know there is a toxicity that comes from ingesting too much at one time. And there's also physiological harm that comes from long-term exposure over decades that leads to cirrhosis and other physiological harms. Meth fits that pattern way more than an opioid toxicity. Excuse me, opioid toxicity profile. So I would suggest kind of thinking of meth as, is that, like, doing the legwork and understanding what the circumstances in those overdoses were, whether it was a toxic acute event and how you respond to that, versus if it's a long-term exposure.
Yeah, very, very important observation. Interesting comparison. How are the health departments collecting samples for your lab in a safe, responsible manner?
So, I mean, the kits are, there's a little vial that allows the sample. It has a little liquid in it that inactivates the sample, and we work with them. We give them a little training, and most of the health departments have SSPs or certain service programs, and they're often the first point of contact with people who use drugs. So often they're collected through that.
Great. And they've passed snuff with the county council and all that because of their engagement with syringe programs and all. Excellent.
Yep. It's
Wonderful.
no more than like the residue you would have from paraphernalia from an SSP anyway. So it's not like you're bringing more in. It's just the same amount.
One person had a question about quantitative testing. Do you think there's a place for quantitative testing?
Absolutely. And I showed the data from Vancouver as an example of the power of quantitative testing. There's a few other partner labs, Center for Forensic Science Research and Education in Pennsylvania. They're kind of the go-to on quant in the US right now. We don't do quant because it's way more expensive and way slower. But I think definitely there's definitely a role for that.
Great, thank you. And some of the local health departments are involved in wastewater monitoring. Any comments you have about that and surveillance or utility?
Yeah, totally. My dad is an environmental engineer who does wastewater. And so we've been talking about this like idea for decades, and finally there's like actually happening. It actually happened here in Wake County, where I live in Raleigh. And this was like an early pilot. And what ended up happening was they ended up um, cutting off the pilot because what they found was the highest levels of drug use were from the richest communities, and the richest communities didn't like to know that kind of thing, and it kind of really challenged them. So that particular pilot got you know cut nixed. But I think we don't use the wastewater data ourselves because we want to give information back directly to people who use drugs, and the way that our kits are designed with the QR code, we think that's the most important thing. Like the surveillance and the data are secondary. They can tell stories, they can tell patterns, but our primary responsibility is to help people make better decisions about what they put in their bodies.
Great. We have several questions regarding this phenomena of drug busts and increases in overdose fatalities. What do you think is what are the mechanisms related to that is one question. And then are there any examples or best practices in communities where law enforcement has recognized this and there's some kind of partnership with public health and law enforcement in
Mhm.
practices?
Right. It's such a challenge, right? It was kind of blew my mind when I saw those studies. I was like, no way, this can't be real. I got to, really dig into them. Um, and so the potential causes. So anytime you disrupt the drug supply, anytime it's something that people are not used to, there will be problems. We saw, for example, when like in Appalachian, rural Western North Carolina, when a local methamphetamine producer is busted and put in jail, what happens is that region gets flooded by cheaper, more adulterated meth from Atlanta. And that meth has contaminants in it, including fentanyl, all sorts of other junk, and it leads people to actually have bad physical reactions, end up in the hospital. And a lot of our EMS colleagues know what those studies say because they'll see a spike in overdoses and or hear, oh yeah, there's a drug bust, like put an extra person on shift because it's going to be a busy night. Like this is something that already happens, compensating around the country. So I think anytime you perturb the drug supply, you're going to have these increases and eventual dips back down. Places that do it well. So I think this is a challenge because cops are not going to tell public health ahead of time who they're going to bust, right? They've spent months and months together to putting the case together, surveillance and all the data and everything, right? To kind of go after one particular person or ring or whatever. And so asking them to do that ahead of time is probably a non-starter, but you could try. What I think is more important is to have like the way that one of the DEA officers told me is like, okay, once the package is secure, meaning like we've taken the drugs off the street, we can tell you, we can call you right after that. And what is it that you would do? And I think that depends kind of like local place to place, where if you're in a rural place or an urban place, I mean, a very simple thing like how do you know right now if there was a huge drug bust, which treatment facilities in your town has open treatment slots and what those hours are? Do you know that off the top of your head? No, most of us don't, right? But that's the kind of information and the networks that we need to have and have a faster response when these big law enforcement actions come down the pike.
Great, thank you so much. There was also several questions with these really alarming statistics about the increase of deaths relative in abstinence-based programs relative to continued use. But most of the questions were, is there data about Suboxone?
Yes, I think that study, I'm trying to remember. I have the reference for the study in there. I don't want to misspeak. Robert Heimer at Yale was the first author on that study, who was one of my former mentors, my first mentor in this work. He's very friendly. You can email him. He cares a lot about BUPE. So just feel free to reach out to the authors of that paper if you don't find the data in there. I know they're following up on it.
But equally effective, not equally, I don't want to say equally, but also effective in
Also effective. Yes, definitely also
Right.
effective. I
Perfect.
feel like we don't talk about methadone enough. So kind of,
Good.
put that out there.
Great. Let's see, there are so many questions. I'm just trying to get to all of them. Can you kind of give a summary that people can use locally about how checking prevents overdoses and how it basically leads to a reduction in overdoses?
Sure. I think it's a really big lift to try to have drug checking be the way that overdoses are declining. I think what drug checking actually does, it allows you to have new conversations with people who were not really fully engaged with your services before. And I think that's where the power is, because when we show people these results, they very often are like, I didn't realize I was putting that crap in my body. I don't want to do that. What are my options? And I think that's the phrase we hear in North Carolina a lot, is like, what are my options? When they see what's actually in the drug supply, what they're putting in their bodies. And so we see it as part of autonomy and respect and kind of freedom, and being a important aspect of helping people make better decisions. Because when they make decisions for themselves, those are the decisions that last, instead of something we impose on them.
Yes, thank you very much. Excellent comment. I know when you were reading through all these very toxic substances, we're looking at overdose, but the medium and long-term impacts of these on individuals' health is also of great concern.
But
In light of funding cuts to a lot of harm reduction research and practice, any tips looking forward for maintaining resiliency for this work?
I think we have to do more to tell our stories. The work, I mean, you saw the two examples from Louisiana and St. Louis. There are thousands of these. Every single person on this webinar has a story, and every single person on this webinar has helped save someone. I'm sure of it, whether it's informally or formally, whether it's handing out naloxone or handing out hugs. You have done something that has helped. If we have 42% of adults who know someone who has died of an overdose, what is our national character? Like, is our national character to say, oh, we're going to have to, like, this is all about what happens in other countries. This is all like stuff that the military has to deal with. Or are we the kind of nation that says, we're going to take care of our own people? We know what the tools are, and we're going to demand that we are giving them, that we get them, and so we can get them where they need to go. So I think that's really the key right now, is that we need to tell the story of how we have made changes in our communities, tell the story of people who are still alive, look at the chairs around the table during holidays and say, yeah, these chairs are full and not empty. And I think that's the message that really needs to get across. And the opioid settlements are here for this. This is like what we need to be asking for it, demanding it.
I can't think of a better response to end this conversation with. It's just, I read in the article about you that you keep photos of individuals who've overdosed on your desk. It speaks to the tremendous humanity you bring to this, and so appreciate the amount of hope you're bringing to people, and just the very accurate information that we can all use to better move forward. It's just an excellent presentation. We thank you so very
Thank
much.
you.
Thank you.
Appreciate it.
Great. Well, thank you all for joining us for just this excellent lecture. We really appreciate it. You will be able to get a copy of today's presentation on the National Overdose Prevention Network website. Would invite you all to look at the website. It has many, many resources on it. We so appreciate all the work that you do. As Dr. Knapp so eloquently said, it is making such a difference. in your communities and throughout our country. Thank you all so much for joining us today, and we hope you'll join us for our next webinar. Thank you, everybody. Goodbye.